Welcome to RhAPPcast, the official podcast of Rheumatology Advanced Practice Providers, where we bring you the latest insights, discussions, and updates in the field of rheumatology. I am your host, Amanda Mixon, the current president of RhAPP, and I'm thrilled to have you here to join us for this very important episode. Today, we're going to dive into a critical topic that affects many of our patients, which is the impact of delaying optimal therapy in those with rheumatoid arthritis and spondyloarthropathies who haven't achieved disease control. We know that timely and effective treatment is crucial in managing these patients, but delays can happen. They happen often, commonly, which obviously can lead to significant consequences for our patients. So to help us kind of delve into this and talk about this complex issue, we are joined by an esteemed guest, Jeannette Hart, who is one of our valued faculty members of RhAPP, also a dear friend of mine. She brings a wealth of knowledge and experience in managing rheumatologic conditions and will provide valuable insight into how we can better manage and address these treatment delays and how we just improve overall outcomes for our patients. So, before we kind of get into the crux of what we're here to talk about, can you give us a little introduction on yourself? Tell us about yourself, how you got into rheumatology, because most of our listeners really want to know that stuff too.
Okay. Well, thanks for having me, Amanda. I'm actually really excited to dive into this topic. But before then, I've been in rheumatology my entire career as a PA, 12 years now. And I got into rheumatology just by way of a mentor of mine. I had a really good friend, Dr. Peacock was his name, that sort of introduced the world of rheumatology to me. I soon came to find out that my mom had Takayatsu's when I was a child, and that was a cardiology managed disease back then. And I came to learn about vasculitis and all of the different manifestations, disease manifestations that I would get to dive into in rheumatology and fell in love with it right away. Haven't left since. This particular topic excites me because I live in a rural community and making sure we get patients in and treated, in an appropriate timing is super important for me. So I've done a lot of work in my particular, clinic for this.
Oh, that's incredible. Well, again, I can't think of a better person to talk to with your experience. And again, this is happening to us, I would say not infrequently. So let's kind of get into some questions and we can chat. What do you think are common reasons for the delay in initiating optimal therapy in patients with RA and spondyloarthropathies?
I wish there were one answer really for this, but I like to kind of stand back, especially when I'm looking at my own practice and start from the beginning. So first of all, the referring providers, I think there's a lot of education that can be done for our local referring providers on when they are seeing these patients. Do they have high suspicion? And if they do have high suspicion, what maybe they should be ordering prior to or as they're referring the patient to rheumatology. Because if all the appropriate labs are done, the x-rays are all done, then it's so much easier for us to kind of just grab the ball and begin treatment at even the first or the second visit. So I think we need to start on that end. On that note is access. So if we get all that information from referring providers and it is very obvious that this patient has hot disease, whether it's rheumatoid arthritis or one of the spondyloarthropathies, we'd have the availability to get them into our clinics. And so I think, thinking about how you can recreate access within your clinic is important too. So we start by thinking about the referring provider. How are we going to get these patients in when they have really active disease? And then onto patient education. Why is it important that they make their appointments? Why is it important that they take these medicines? And then lastly, I think about guidelines and ensuring that everybody within my clinic's on the same page as far as best practice goes. So I think it's multifaceted and we really need to kind of tear it down. If we're having an issue getting our patients on drug and getting their disease treated appropriately, we should look at it from all the different facets.
Yeah, I couldn't agree more. I mean, I think about across the country, the length of time to see a rheumatology provider, and sometimes it can be months. I've even heard of cases where it's years, which just blows my mind. But it's challenging, right? Because again, it takes so long for these patients to get in. And to your point, if the referring provider doesn't know what labs to order, or again, just that lag of time. Sometimes, we get a patient. I had a patient recently that I saw for a new consult, and my gosh, this person has been struggling for months and months, very clearly has an inflammatory arthritis. And, time is, joint damage and tissue and all of those things. And, obviously, for what I see, that big one is just the time it takes to actually see a rheumatologist or rheumatology provider. And then I also agree with you on the focus of the patients. I mean, I was talking to a patient today about this, about, why we want to get on top of therapy as soon as possible, because we want to prevent those things from happening. And, again, sometimes patients just aren't quite there, in terms of their willingness and readiness to like start a therapy. And they don't quite think of it as, they think of where they are today. I think it's challenging because, we have to think about where they're going to be 10 years from now. And, if we do nothing. So I totally agree. And this is really going to kind of get into my next question, which, what do you think are these kind of potential consequences of delaying therapy in these patients? And, how does it impact their disease progression and overall quality of life?
Well, I think first of all, the canned answer is they will have irreversible joint damage, right? We know that as the canned answer, and that's the sort of the reason behind wanting to treat early and aggressively, especially when it comes to rheumatoid arthritis. There's a lot of data to support that. But beyond that, I think we want to develop trust with our patients. So I can't imagine having a new disease, being told it's chronic, and then knowing that every single one of our drugs takes up to 3 months to full efficacy, right? And so we keep going back to our doctor, and maybe we're getting incremental improvement in our disease activity, but we're not being treated aggressively or optimally. And they may lose trust in us if we're not quite, moving this along at the cadence that will get them to low disease activity or even to remission, which is what we expect nowadays. So I think really the patient gaining that trust that we can get them there. But if we're not seeing them back in appropriate intervals or asking them to come back in 3 to 6 months when they have active disease, because maybe we don't have the access like we talked about earlier, or for other reasons, maybe we're just stuck in the same old way that our mentors ran their practice, and we haven't tried to change how we do things. I mean, there's opportunity to virtually see our patients. That's nothing I would have thought about when I first started practice. We can check in virtually. We can look at their labs. We can titrate doses, all without having to drag a patient into the clinic. So there's no reason for our patients to be waiting months and months to get in. And to your point, with the new patients, these patients may be on steroids for a really long time before they get into the clinic. They're going to be pretty upset about that. Maybe they're feeling better, but by the time you see them, they're starting to see the sequelae of long-term steroids. And so I think that is definitely one of the consequences of not getting treatment is the result of the steroids, potential mistrust. And so in a nutshell, there's a lot to say beyond the warning of irreversible joint damage.
Absolutely. You're dead on. I totally agree. And so much, you're right. So much of it is like building this trust with our patients, right? Because you're right. Imagine, who gets diagnosed with these things, right? Younger people. I still consider myself young. And so,
you are young.
If I were diagnosed, like, how would I feel about that? Immediately people can go on the internet, and I think it's not quite as grim as it used to be, but it's like, they start to read about these things, and then, they start to read about the medications and the potential risks associated with the medications. And it's just so much trust and education needs to be done early on so that, again, it can lead to these better patient outcomes in this long-standing relationship. I kind of think I know the answer to this, but why do you think early intervention is so critical in managing these patients with RA and spondyloarthropathies?
I think it goes back to, we don't need these patients to have damage, right? We don't even need them to have a deformity anymore. We don't even need them to have fusion of their spine anymore, to say that they're being treated well. So I think getting the patients in, getting them treated aggressively, creating that trust where they're going to adhere to their medications, which only comes with sort of repeating ourselves. I think every visit I almost ask my patients, now, do you remember what's actually going on in your body? Do we need to talk about it again? Because maybe this drug that we currently have you on, it looks like you're doing a lot better, but we might be able to improve even further if we switch medicines. And I think we're going to get into this, further on in our conversation too, but complacency as a provider with saying, okay, we have some improvement, and maybe the patient was the disease was so active in the beginning that they're willing to stick with any improvement. And I think it's our job to say, you're right, things are better, re-explain the disease process, re-explain all the different mechanisms of action we have now drug-wise, and say, but I think we can do better, and we should try. We really should try, because there's just not any room in rheumatology for that complacency.
I totally agree. I mean, I feel like you're right. It's complacency on both ends. A lot of times patients don't want to change because they remember how they felt. And I have to say, sometimes I've done the same thing. I don't really want to change because I remember what they looked like. And, I don't want to, sometimes maybe I have a preconceived notion that if I change you, what if you flare? What if we go backwards? And so I kind of have to remind myself of that too, that good is maybe not good enough. And, we
Right.
can move on and change. And we have so many wonderful options for patients that to your point, there really is not a reason why we shouldn't be, potentially changing, adding, et cetera, so we can get them under control.
I think,
yeah. No, go ahead.
Yeah. A wonderful story just from maybe a month ago, a patient I've been seeing my entire career. And that's what's kind of nice. I've been in the same clinic for all 12 years. So I get to follow these patients. And she has chronic rheumatoid arthritis patient, chronic deformities. She's got fibrotic pannus too. So, sometimes you can't tell if there's actual active disease or whether it's just chronically there. She was on an IL-6 inhibitor, which meant that I couldn't really follow her labs for disease activity. She loves to exercise. This woman lives on the river and runs on the river. She loves to exercise. And just for 3 or 4 visits in a row, I noticed she was down, and she was frustrated because she wasn't able to exercise like she once was. Both she and I were comfortable in the medicine that she was on. Labs supported that she was doing well. Her physical exam, really didn't change all that much. But I kind of looked at her and she's like, Jeannette, I'm not sleeping through pain. And I started listening to things that I can't see, her subjective story. And I thought, oh my gosh, let's try something. It's not that we can't go back to this other thing we were doing, but I think we ought to try to change. And I'm not joking you, after I switched her to a JAK inhibitor, she came skipping in after 4 weeks, gave me a hug, tears. And it's all because we just took that minute to think, maybe this isn't good enough. And now she's back to her old self. So just a quick anecdotal story about just making that leap sometimes is worth it. And you're right, sometimes it's not. But those moments that where it's worth it makes you want to continually try to improve your patient's quality of life.
Absolutely. And, I think to myself, how many times have I made the change and regretted it? And in the 17 plus years I've been doing this, maybe once or twice where I've really thought maybe that wasn't the best choice. Was the patient really active or what, so, it's probably happened a handful of times, but again, not so much so that I can really think of it. So how do you feel like healthcare providers can identify these patients that are at risk for not achieving disease control and kind of ensure that they continue to, overcome these barriers?
Yeah. I think we have good tools, first of all. A lot of people, for a long time didn't want to talk about disease activity scores like the CDI or the BASDI for AS. But I think they're there for a reason. And they can sometimes, even though you really rely on this clinical intuition, those scores can support it. And it gives you something to say, you know what, I've been watching this, I've been trending this. And while I say maybe mild disease, this is showing me that you're actually starting to develop moderate disease. And so I think we ought to not only just use those for payers, which is why most of us are inserting those into our chart notes, but we should look at them and just see if they can teach us anything. They're not always right, but I think they're helpful. Also, I think that we are really great physical exam providers. I think in rheumatology, we've been taught to do the same physical exam over and over again to make sure that you know what normal looks like and you know what abnormal looks like. And we don't forget to listen to lungs and look for end organ involvement. So I think really relying on a physical exam. And then lastly, listening to the patient, just like that story I just told. Maybe they've been complaining about fatigue for a really long time, which is one of the hardest complaints to address. I understand. But then maybe if you dig a little deeper, okay, is that morning stiffness getting worse? Is it more than just fatigue? And listening to those patient reported outcomes, really can help us put the whole clinical picture together and then decide, okay, is it time to change? Is it time to up titrate whatever we're doing? So I don't think it's just, there's ever one good answer for this, but if we use all of our tools, we can do so much better. We can do right by our patients.
Yeah, I couldn't agree. So it's really listening to the patients, using the tools that we have, the physical exam, like putting all of the pieces of the puzzle together.
Yeah.
What do you think are some barriers that maybe healthcare providers face in initiating optimal therapy promptly?
Right.
Obviously, some of it are the insurance requirements, but what else?
Yeah, I argue that too, because I don't think it's that hard to, the insurance is only giving us, a big no because we're not following their algorithm. And as long as the drug we're using it is within guidelines, you shouldn't have that much difficulty. So I kind of blame ourselves for our own problems. Specifically in my clinic, I talk about sort of all of us working together, not just the providers, but the MAs, the auth team. And they can't do their jobs if we haven't done ours. So make sure our chart notes have every single drug that they've tried and failed and why, so that our support staff can help us get these drugs approved. Because then you often hear, oh, insurance companies are denying, I have to appeal, I have to write letters, and it's like, well, if all the info was always in your note and we did that work in the back end, then moving forward, you can really, really lean on your support staff to help you get things approved. So yes, payers make it hard, but we have to look at ourselves in the mirror a little bit and make sure we have all the tools in our notes that our staff can help us get things approved.
Okay. So, lastly, I want to ask you've already given some really, really great, I love the stories. I love the idea of also holding ourselves accountable, and because it's not, oftentimes we just hear, oh, the patient didn't want to do this or they're not following up, etc. But I totally agree, looking in the mirror and saying, well, what can we do better as providers to ensure that we are achieving, the disease activity of low disease activity remission that we're looking for? What best practices do you have to ensure that patients receive this optimal therapy, without these unnecessary delays?
I think the best advice I would give and what I give to myself is get creative. Just because your mentor did it a certain way, if you get comfortable enough to now look back and say, how can I make this better? Do I need to change how I'm seeing patients back? Can I use virtual? Can I use, maybe my nurses to run a disease activities score? Do my patients that are stable really need to be seen that often? Is that what's clogging up my schedule when I need to get these urgent patients in that have high active disease? So I think getting creative and stepping back and looking at the big picture. Why am I not getting this drug approved? And why is it consistently one particular payer? Or is it because I'm not doing a great job on my charting? Am I misunderstanding guidelines? I think just a questioning attitude is good all the time, right? I think it does some good as a provider to have one of those. And then again, like I said, big picture approach to things to see how we can better, how we can better treat our patients.
I love that. I love the first thing that you said about just not doing things the same way, because this is an evolution. Rheumatology is an evolution. The time that you and I have been practicing, we've seen so many new therapies, new ways to diagnose, all of these things. Right. And it's important. We have to evolve and continue to learn and grow, which, again, is why I think RhAPP is so wonderful, because that's what this organization is about, and constantly helping us to achieve that so that we do learn. And, again, thinking outside the box, how better can we do things, looking at our schedules, et cetera. I could not agree more. And, I think that this whole discussion has been so insightful and helpful, and hopefully helpful to our listeners, which wraps up another episode of this RhAPPcast. And I really hope that the discussion has shed some light on this critical issue about kind of delays and why they might happen. It's not only just access or only just insurance, delays, et cetera. It's so much bigger than that. And I think we need to all kind of look in the mirror and see what we can do, to do a better job for our patients, because ultimately that's why we're all doing this. Again, thank you so much, Jeannette. You have such valuable insight. Yes, I so appreciate it. Again, your stuff, and it's very, very easy to see. So thank you again.
Thank you.
To our listeners, thank you so much for tuning in. We hope that you found this episode informative and useful in your practice. If you enjoyed today's discussion, please subscribe to RhAPPcast. Leave us your review. Your feedback really helps us in terms of what content you want to hear, etc., things we can do better, more, etc. And don't forget to visit us on RhAPP.org, as well as our social media accounts at RhAPP. We have education rolling out constantly to help keep our members up to date. So until next time, this is Amanda Mixon signing off so please stay informed, stay engaged, and keep making a difference in the lives of your patients.